Well, good afternoon, and thank you, Leanne, for the welcome. I'm Andrew Baird. I'm a GP, actually in St Kilda, 2 kilometres further away. I'm also a medical advisor with one of the medical defence organisations. And really, just as Leanne said, did it ever go away? So hopefully in the next 15 minutes I will attempt to cover the key features of pertussis and its prevention in the context of the resurgence since 2024. I'll present the pertussis file describing what it is, how it does it, and why there's a problem. I will then try and illustrate the problems with some charts and propose some possible solutions to address the problem. You know, I'm a late arrival. I wasn't here yesterday, and I've just noticed that, and this has probably been commented on already, but the pattern on the carpet here is Bordetella pertussis on a rich culture medium. So I think that's very well organised by the Immunisation Coalition. So to set the scene, here are the opponents. This represents Bordetella pertussis. It's an aerobic gram-negative coccobacillus with several virulence factors. The red asterisked proteins are used as acellular pertussis vaccine antigens. Pertussis toxin is detoxified, the others are purified. So Bordetella pertussis wasn't known by that name when it was first isolated by Bordet and Jongu in 1906. It was formally named Bordetella pertussis in 1952. In French, the T is silent, Bordetella. However, in Latin and in microbiology, it's sounded, so Bordetella. So Bordetella's other opponents in Australia are the vaccines listed, noting that the adolescent and adult formulations, lowercase p, have a reduced dose of pertussis antigens compared to the child formulations. Monovalent acellular pertussis vaccine is not yet registered for use in Australia. Trials are in progress, and there may be others in the room or online who can enlighten us on that. Pertussis vaccines are effective across all age groups. However, like infection-induced immunity, vaccine-induced immunity wanes over time. Take-home message, and I could go home now, pertussis immunity needs priming and needs boosting. This slide attempts to cram the clinical and diagnostic features of pertussis disease into a single timeline, noting the classical 4 stages of the incubation period, followed by the catarrhal, paroxysmal, and convalescent stages. Please note the blue line for PCR testing in the catarrhal stage. That will come in useful later. Okay, Bordetella pertussis. This is the profile. The ultimate uninvited house guest who won't leave when everyone else has gone home. So here's what we're dealing with. A highly communicable bacterium, but not from 3 weeks after the cough onset or after 5 days of antibiotic therapy. Bordetella pertussis's presentation is atypical to adults and may be overlooked, particularly in general practice where I work. There are 3 to 5 yearly peaks in its endemic circulation. A plot of pertussis severity, hospitalization, morbidity, mortality against age is a U-shaped curve with higher vulnerability at the extremes of age. So the very young and the older people, particularly older people with comorbidities. I'm not going to present data on that because it's quite confusing. I don't really understand it. And other than symptomatic persons, the principal contributors to the pertussis reservoir are asymptomatic or mildly symptomatic adolescents and adults with waning immunity. And there is macrolide resistance. I read, and I can't remember where, that macrolide resistance may be up to 98% in China, but not a problem in Australia at present. Now I'm going to present 10 charts in rapid succession, so brace for impact. Since 2000, the number of reported cases of pertussis globally has been around about 200,000 per year. There was a dip during the pandemic years, and then a surge approximately heading for about 1 million cases in 2024. If we look now at Australia, same pattern, showing pertussis notifications by jurisdiction over the past 30 years. So you notice those little waves, the 3 to 5 yearly blips of increased incidence, but also this massive surge in 2024. So I'm going to drill down on the dip and the surge. This is in the Australian context. So in 2024, 57,257 pertussis notifications. Interestingly, 7 times higher than the incidence in New Zealand. And if we have time, we might talk about why that happened. Now, to put things in perspective, 57,257 notified cases in 2024. The number of influenza notifications and COVID notifications in that year were each about 6 times higher than the number of pertussis notifications. So here are the influenza charts, and here's the COVID chart. Noting that this COVID chart is logarithmic to account for the 10 million notified cases in 2022. The next 2 slides show the number of notified cases of pertussis in Australia by age group. Firstly, over the period from 1991 to 2026. And secondly, this is showing it for last year. So pertussis disease is really about infants and children, but not exclusively so. And that's the cruncher with pertussis. Interestingly, in 2022, that's when we had the nadir of 484 cases notified in Australia. There was actually a more even distribution of pertussis across the age groups. I'm now going to talk about maternal vaccination, and guess what? It works. These are Australian data. So comparing the pre-maternal vaccination period, 2010 to 2014, with the post-maternal vaccination period, 2015 to 2019, the notification rates of pertussis have decreased across all age groups to age 4. Now, if you look at the top left chart, the maternal vaccination bars are in orange, and the post-maternal vaccination bars are in green. The percentage reduction in pertussis rates has been from 90% for infants less than 2 months of age, up to about 9% for children aged 2 to 4, and that's in the chart on the top right. There is a concern that maternal vaccination may reduce an infant's immunological response to pertussis vaccinations, so-called immunological blunting. But, and this is my understanding, that doesn't appear to be clinically significant. Australian data on maternal vaccination are not easy to find. The best I've got is a maternal vaccination rate of above 70% for the period 2016 to 2020. I couldn't find any information on the Australian Institute of Health and Welfare because they stopped collecting it. So what do we do in Australia? And what are our recommendations? Well, here's a copy of the National Immunisation Programme, and I've attempted to summarise what's written in the Australian Immunisation Handbook. So, how are we doing? Well, here are 2 slides showing that fully vaccinated coverage has been dropping for all Australian children and for Aboriginal and Torres Strait Islander children from 2000 to 2024 at each of the 12-month, 24-month and 60-month milestones. We are below the 95% for community protection. So this is for all children, and this is for Aboriginal and Torres Strait Islander children. And it's not looking good for adolescents either. So coverage for DTPA in adolescents in 2024, below 90% for all birth cohorts. And if you thought that was bad, let's have a look at people over the age of 50. So for DTPA in adults, the numbers are abysmal. And I'm going to show two slides. This is for all adults. The paler color is for the ages 50 to 64. The darker color is for ages 65 and over. So we're getting roughly about 1 in 4 adults over 50 who are vaccinated against pertussis. And it's the same for Aboriginal and Torres Strait Islanders over the age of 50, about 1 in 4. So now I'm going to look outside Australia. Let's look globally. So overall, globally, DTP3 coverage is around about the 85% mark. Now I'm going to show you 2 clubs and some of their members and what they're doing. So firstly, here are some members of the DTP3 99% coverage club, and some of the features that may underpin their success. Access, health worker networks, political commitment, and robust data systems, so collection and use of data. But these do not cover pregnant women, adolescents, and adults. Now, we've got another club. This is the DTP3 below 60% coverage club, and some of the features that may be relevant for their lower coverage: conflict, poverty, infrastructure, geography, and the diversity of language and culture. So what now? How about some blue sky thinking? Let's have a go. How about reducing transmission and reducing the reservoir of pertussis? Improving vaccine uptake, data collection and surveillance. What about improving detection? Remember that blue line for PCR testing. And intervention, such as isolation and treating with antibiotics in the earlier stages of the illness. And what about reviewing global strategies? Standing on the shoulders of giants, looking at what others can do. And a bit more blue sky thinking, a bit more of this, and a bit less of that. And I'm not going to read through everything that I've suggested on that slide, but I suspect it probably echoes themes that have come out from many of the earlier sessions. Limbs, particularly non-child limbs, taking throat swabs early in the illness. Although, do we really want to be taking throat swabs from people with pertussis in general practice? I haven't really thought about that. Collecting data and surveillance, improving access, more vaccinators, nurses, nurse practitioners, pharmacists, GPs, implementing a recommendation and funding for 10-yearly DTPA for adolescents and for adults, more targeted and opportunistic vaccinations, using systems, and I'm echoing what Paul said in the last session, the importance of systems in implementing vaccination programs. Using, and we've got a great resource, sharing knowledge about immunization. Perhaps we should be using it. Drones. Can we use drones? We can. We can. And less of the things that we want less of. And I might suggest less DT. If there was less DT, we might have more DTPA. Interesting thought. So no country provides recommendations, free vaccine, and free vaccine administration for 10-yearly DTPA boosters. But it seems to be one of the ways to go. I've shown some examples. Belgium, Austria, Finland, and New Zealand provide some of these, but not the full package. I've included Rwanda here because they do use drones as part of their way of distributing vaccines around the country. Rwanda is an exemplar for childhood and adolescent vaccination, not for adults and for pregnant women, but could we be using their models to help us improve our vaccinations in those groups? Nearly finished. Just want to do a quick shout out for Gavi, the Vaccine Alliance, which supports these 54 countries, many of which do extremely well in their vaccination programs, albeit targeted at children and adolescents. And if you're thinking ahead for what to do later in the year, how about There we go. My last slide, which will not show, is actually a flyer for the 15th International Bordetella Symposium, which is being held in Nashville, Tennessee. That's Dolly Parton country. So if anybody's interested, register. Thank you, everyone. That's thanks, Anne.
Thank you, Andrew. That was quite a limit. Don't go away because we don't have a panel discussion at the end. So we've just got a couple of minutes for any questions. Sure. I haven't got an online question yet, so do we have any questions from the audience? Just if you can wait for a microphone for the online people.
What are your thoughts about the difference between the acellular and the non-acellular pertussis vaccination? There's been some thought that one is more effective than the other.
There is good evidence that the cellular vaccine is considerably better and provides longer immunity, less waning than the acellular vaccines. Absolutely true. But my understanding is we probably have difficulty reintroducing cellular vaccines in Australia due to the adverse effects with the cellular vaccines. I mean, I suspect most of us in this room were vaccinated with cellular pertussis vaccines, and the risks of the high risks of high fever, seizures may be unacceptable. But yes, a very good point that and I didn't show figures, but certainly the cellular vaccines have much less waning than the acellular vaccines.
Okay, I've got a question from Rob, and then I've got an online one.
If we get a pertussis-only vaccine, where do you think its place best used? And say it comes here next year, what would you like to see where it was and what happens with it?
Great, thanks, Rod. I would love to see it. The more, the better. I wouldn't see it as replacing the DTPA. I would see it as another option for those who don't wish boosting of diphtheria and tetanus. My understanding is that it's currently where it's used in Thailand and Singapore. It's not registered for use under the age of 3, so we've got a limit there. But it would be great to introduce that, and together with a 10-yearly adult booster program as another option. I guess there'll be cost issues. I don't know what cost the new monovalent vaccine will be, but there's certainly a place for it, but not as a replacement.
So my online question is, and I think that it's probably a comment as such that I think everybody would agree with, is it time to replace the doctor's bag PBS funded ADT with a DPTA? I don't think we'll get any disagreement here,
I've got a very long answer to that. Yes.
Yeah. And this is the thing, and this is constantly, we see this where people have had a tetanus-prone injury and they've been given this in emergency or in the after hours. I've got a question, and that is some of the local obstetricians are telling the fathers and the grandparents that they should have a booster at 5 years, not 10 years, which is not in the handbook, and we get these very anxious parents and grandparents.
Okay, there's no evidence to support that, but it's not harmful. So if somebody's wanting to be 200% sure, why not do it if they've got the extra $30 to pay for it or thereabouts? I do notice that Austria recommends a 5-yearly interval, so perhaps that's emerging.
Perhaps we've got Austrian obstetricians.
Exactly.
One last question, and then we'll go to the next one. And this is because you mentioned you were going to talk about the difference with New Zealand data earlier, but we didn't catch that.
Well, because I was going to bounce it back as a question, because I don't know. And what is interesting, and I did have another slide with it, is the coverage of DTP3 in children and adolescents in New Zealand is much lower than it is in Australia. We're around about the 65 to 70% mark. So there's quite a discrepancy, a poorer vaccination coverage, but a much lower incidence of pertussis during that surge in 2024. I don't know, and I can't find any information. So if anybody knows, please help us.
Perhaps it's less populated and colder.
Could be.
Okay, thank you very much, Andrew.
Thank you, Leanne. Thank you.